Welcome to another episode of One on One. I'm your host, Justin Gick, and today I'm talking to Dr. Charles Barbera, the Vice President of Pre-Hospital and Unscheduled Care at Tower Health's Reading Hospital in Reading, Pennsylvania. Dr. Barbera graduated from LaSalle University's Communication Department in 1986 and participated in student government and was an RA. Dr. Barbera, thank you so much for joining me today.
Oh, this is fun. Thank you.
So let's just jump right into it. Tell our viewers a brief description of your job and how you got here.
I was a communications major at LaSalle, and I had done Brother Jerry had put me in an internship at St. Agnes Hospital in the PR department, and I had kind of been interested in science off and on, but I wasn't. I wouldn't say that I was a studious kid by any means. But I got interested enough during that internship to see, what would a medical career look like. So I actually then, make a long story short, went back to school and wound up going to medical school and doing a residency. I'm an emergency physician by training, and then wound up here. Well, actually, I wound up at Reading Hospital, and they had made me chair of the department, and at that point, I had gone and gotten a master's in business.
Tell me what your finest memories of LaSalle are.
Wow, I have a lot. I think that there were I think student government is kind of where I felt like the support there was really good. I very much liked the activities that student government did at the time. The campus was much different, and I have been back probably within the past year, and really wouldn't recognize the place, and that's cliche, but it is true. It has expanded. It really has expanded. The other was being an RA. I very much enjoyed the residence life aspect of LaSalle. I had Hillary and George were my two dorms. I did it twice, and that was kind of neat. It was kind of a time for a kid like me to sort of have a little bit of responsibility and whatnot. So I think that they were fond outside of the classroom memories.
You did your residency at Jefferson Hospital in Philadelphia. Tell our viewers what a residency is and what you had to do while completing it.
Oh, all right. So a residency. So when you go to medical school, you do it's kind of broken into phases, right? And so I went to Temple University Medical School, probably the best, and it's great, and I'll give a plug for it if anybody listens. So if you're going to go to medical school, Justin, I would tell you to go to Temple. So you go to medical school, and what they do in medical schools, they kind of teach you, like what the body is in year one. And then in year two, they teach you what could go wrong with the body, right? And then in year three, they teach you with patients, like what are the most common things you'd see with patients. And then in year four, they say, kind of go and figure out what you want to do, right? And because, at that point, and this was 30 years ago, a lot of people didn't go into primary care. You had to kind of do something and create your niche. So I chose emergency medicine. I chose it really at the last minute, which is pretty typical of my whole life. But and so emergency medicine has evolved, but really it is the specialty where you work, and you can work pretty much anywhere, but mainly in an emergency department. And so Jefferson Level 1 Trauma Center, obviously the Neuro Center, the Spinal Cord Center, the Burn Center, all those things that Jefferson at the time had, Wills Eye. So many emergencies come in, and you've got to kind of very quickly decide what to do, right? And so, what's it like? Well, again, much like everything, it's graduated. So your first year, you kind of find out where the sleep quarters are, where the cafeteria is, and maybe how to write a prescription. And they don't let you do too much damage, and they kind of put you in the fast track, and you kind of like, we'll do some stitching or whatever, and sewing and that stuff. And then as you go on, you kind of come in with really complex people. And then finally, when you're a third year, you're in the trauma bay. So you're seeing the gunshots and the stabbings and the car accidents, plane accidents we've seen, like those kind of things that people come in. And and you got to figure out, well, a couple things, like what has happened, right? What do I see in front of me? And then what's the next step? And it's not always as textbook as you might think. I mean, certain things are, right? You get a cut, you clean it out, you sew it up, you put them on antibiotics, you go. But certain other things aren't as clear cut. And that's what you learn in residency, is like, where do I get this experience? So not necessarily I'm going to see the same exact thing, but these principles, much like in communications, how can I apply these principles that I learned to a situation that might be different?
So you mentioned seeing a lot throughout your career in emergency medicine. Have there been times when you've seen things that made you want to stop being a doctor?
Never. I mean, I've seen a lot of sadness. There is, and every physician has, but you see child deaths and you see child murders. You see people taken from this world far too soon. People that lose limbs that their livelihood depends on it. People that lose the ability to speak or move their bodies or those kind of things. People that lose everything in a fire, right? All these things. I never ever left. I don't think I could ever say, other than bureaucratically. And bureaucratically, yes, there are things that happen. But in the patient care realm, no, there's always much to do. And the thing in medicine is that I do believe the Lord gives you a gift, and you really have to use that, right? Because not everybody goes to medical school. Nobody can do that. So it's not something like a light switch where you can just turn it off, or at least I haven't found that.
Reading Hospital was accredited as a Level 1 trauma center in 2018. It had been a Level 2 since 2005. Were you involved with this turnaround? And if so, how were you able to do this?
Actually, yeah, I opened the trauma center. And yeah, I happen to sit on the board of the Pennsylvania Trauma System. I'm the vice chair of the board of the Pennsylvania Trauma System Foundation. So what is the difference between a Level 1 and a Level 2 trauma center? We were always a Level 1, to be honest. I would say we are the only trauma center in Berks County. So trauma never left us. The difference for us going from a Level 2 to a Level 1 was scholarly activity. So we did some research. We started being a research institution. And now we partner with Drexel and we do a lot more research. So we do basically clinical research. We do some bench research, but mostly clinical research, looking at what are the interventions that you do with an elderly person that is on a blood thinner that falls, right? And how do you make sure, because the mortality is very high if you miss an injury. Justin, if you fall and are on aspirin, you're going to be fine, right? But if you're 65 and you fall on aspirin, that's a different problem. And how do you triage that without going through the entire trauma system? So to call a trauma alert is thousands and thousands of dollars. So how do you do that? And how do you identify those people most at risk and intervene with them? So that was the kind of things we had to do and get going to get our research up. And then the second thing was a Level 1 needed a residency program. And we, at that time, we do now, at that time when we went for Level 2, we didn't have surgical residents. We do now. So that was kind of what the transformation was. Our functions and our activities were always at a Level 2 because there was no Level 1 in the area.
first heard about the coronavirus, did you think that it would become a pandemic and last for the amount of time and cause this much loss?
No, I mean, I didn't, we likened it to Ebola at the time, or the swine flu. I mean, we've had a bunch of these things where we've had to stop, regroup. When Ebola came through, and we never got any cases in, we all stopped and we all made sure we had preventative measures for if somebody were to come in with symptoms of Ebola, and had the Ebola room where the person would be brought and call the Department of Health and know how to collect lab specimens and whatnot. So I think many of us thought, okay, is this going to go away? Now I think it's on us to actually, Justin, we have to live with this disease. We have to very much live. So, in the beginning, I thought, well, Ebola and Corona are the same. It's going to be a fad, it'll go away. Now it's more like an HIV, right? This is out there. We are all at risk one way or the other, but we know how you get it, right? So we know how to mitigate that risk because we know how it's transmitted, and we know what the measures are to preclude the transmission. Not always pleasant, not always things that we want to do or are used to doing, but we know, and we know how to protect ourselves. And it's on us to make sure that we can develop a life for our society that is responsible. Masking, and then I put the mask on. This is important. I wear it all the time. What does it do? It actually stops me from giving this to you, Justin. Now we're on the computer, but the mask is good. It's helpful because much of it is spread through saliva. And so when people are masked, it decreases their risk of transmitting the disease. Washing your hands. Again, washing your hands. This is the stuff that, and it's being courteous. And so I think that we really need to do two things. One, mitigate the effects medically of this disease, right? And make sure that we know how to treat it. And there is more promise. I think we're seeing less and less people that are having adverse outcomes for the disease. We've identified the at-risk populations. We've segregated it. It's not pretty. It's not pleasant. But, we are making sure that we can do that. And then secondly, we have to develop a way to go on. Because living, I think, with life on hold isn't going to be sustainable. We're social creatures. We've evolved to be social creatures. I'm not sure that we're gonna be successful another year in quarantine.
We're seeing 3 companies testing possible vaccines. Do you think the first round that becomes available, everyone should run out to get, or should they be cautious?
Yeah, I think we need to mitigate this disease before we know we get a vaccine that is not. Again, there's 2 things with vaccines that I would think you'd want to make sure. One, is it effective? The second, which is a little harder, what are the effects? Is it safe, right? So, you might have something that kills the virus, but it may also damage the host, us. And so you wouldn't want that. And sometimes with vaccines, it takes time, maybe not time to look at the first and say, okay, this bug is susceptible to these immunoglobulins. That's kind of the easy part. But what else do these immunoglobulins attack in your body that we haven't thought of? And sometimes you don't pick that up right away. And so I would say that we really need to be cautious about any vaccine that doesn't have that track record and hasn't gone through a process. Now, does it need to go through as long a process as the HPV or some of the other vaccines that were kind of they weren't necessarily treating potentially life-threatening diseases. Maybe not, I don't know, I'm not an immunologist, but I would say just because somebody has a test tube of something, Justin, and they say, hey, here, come take this. It's just like the guy in the bar that wants to give you a shot of whatever he's got. You know what? You can be cautious. Go wait for the second round.
So tell me about this new virtual ICU system at Reading Hospital that was implemented during the pandemic. What have the benefits and the negatives been?
The virtual ICU basically is an ICU that is based in Reading Hospital, but monitors the other intensive care units in the health system, especially with regard to the whole COVID center. So what we know about COVID, for example, it basically affects the lungs and winds up in respiratory failure. So what we have lung specialists available 24/7. And so our health system, as we talked about, we have 7 hospitals that we would need to get an intensive care doctor to evaluate a patient. And so what the virtual ICU does is it gives us 3 different kind of screens. One where we can monitor all the, I would say, objective data, which would be their oxygenation, their blood pressure, their lab reports, anything, their trending of where they are, right? 2 would be a Zoom where we just see that patient, right, and their ventilator. And then 3, anything else we would need to do to put in orders or to pull up x-rays or whatever. And so we would just basically have, it's a huge Zoom where we could monitor every patient in the health system that is on a ventilator or in an ICU. And we started with COVID, now we're doing strokes, we're doing cancer, we're doing other diseases from the ICU, but it allows our pulmonologists to stay in Reading rather than travel a half hour to see someone in Phoenixville and then have to go to Pottstown. We are able to facilitate that care from one spot. And obviously we have boots on the ground in advanced practitioners at all the facilities that can carry out the orders and do the assessments.
Do you think we will go back to our normal before the pandemic, or do you see a lot changing after the vaccine is available?
I mean, there will be a new normal. It won't be. It will be, I think it'll be similar, Justin, to 9/11, right? The airports will never be the same, right? And we won't ever be the same, right? We will worry. Again, coronavirus is one thing, but it's one of many viruses, right? I mean, the norovirus comes every winter, and you know, these mitigation things, there's a couple things here. The mitigation tactics that we've taken for the coronavirus actually work for seasonal flu, right? And for norovirus and for those other winter illnesses we see. I wouldn't be surprised if we continue these measures, if we really cut a lot of those other infectious diseases down that tend not to be as fatal and therefore not get as much airtime, if you will, but are spread through very similar mechanisms than the coronavirus. So I think there's going to be a much higher emphasis on hygiene and distancing in the future.
Back in 2018, you received the Hero Award from Tower Health for your work with substance abuse and implementing a warm handoff procedure. Tell me a little bit more about this.
Okay, so the warm handoff was, so what we see, and we've talked a little bit about this, Justin, is what we see is is that many overdoses wind up in the emergency department. And what we did here at Reading was we decided that we would not let one overdose leave the emergency department without having a peer recovery specialist talk with that person. So what is that? That is someone that has overcome the disease of addiction. So a recovery specialist is in the emergency department 24/7, And when an overdose comes in, that person goes to that patient and explains to them what the process is and actually walks them through a warm handoff through the detox process. And why it's worked and it's gotten recognition is because it really takes the patient through. When you treat, when an overdose comes in anywhere or substance abuse, and you send that patient back out to the same environment that enables their disease of addiction, you are not going to be successful in treating that person, and the person's not going to do well. So it's very important to provide support that is not the support system that's enabling, but a support system that's empowering, that allows that person to know that they are going to be successful, to help them get into treatment, to help them get a job, to help them navigate the process. And it's a difficult process. And so that's what the warm handoff is. And that's and it's been successful to model now used around the country, actually.
I see you give back a lot to the community, and I think you helped during the Papal visit. What has been the most interesting being involved in the community?
Yeah, I have. I guess I have been involved a lot, and here it's kind of neat in Berks County because that's where one of my offices is. It's a lot smaller, so I walk to work, and so you get to know the community you live in, and it is very helpful to know, because then you can experience what the needs of the community are. And so if you get into a position where you can do things to help the needs of the community, you're right there. You know them. Or if you have a patient or somebody that has a need, you'll know the resources in the community to be able to refer them to. So that is helpful. The Papal visit was kind of interesting because, I'm Catholic and I'm an ER doc, and that's what they asked for. So I was like, wow. And it was really cool going down there and spending 4 nights in a tent down there, right outside the cathedral. I got a great stand. Like where they gave me, I couldn't have gotten I got a great location.
What advice would you give to students who want to go into the medical field, or anyone on the fence about going into it?
I think the thing to do is to explore it, right, Justin? Make sure it's what you want to do. Just like communications, medicine means different things to different people, right? So when you say you want to go, you're going to major in accounting, people think he's going to be an accountant, right? I mean, you say, you're going to major in communications, people say, well, what are you going to do with that, right? So you can do, there's a variety of medicine that goes from psychiatry to pathology. I mean, you can deal with just the mind, you can deal with just the deceased, you can, and anything in between. And so make sure you have an idea of that, because it's a little bit overwhelming. It's certainly rewarding. I mean, I wouldn't have chosen anyone. I mean, you hear people say, oh, would you do it again? Yeah, of course. Yeah, I would. I mean, I was lucky. I was very lucky that, that things worked out for me. And it's very cool. It's interesting and it's fascinating, and it changes every day. So it's not like it's a job that you can just kind of put your feet up and say, okay, been there, done that, I'm going to coast, because you can't. It's not, that's not the way the world is. But make sure that it's not, I got to say, we have residents now, and the residents will come to me and ask me these questions, and then you got to say, it's probably not easy, right? And so there are much easier ways to make a living, so you do want to make sure somebody has the passion, that you have the passion for it, because the passion, I think, is what will get you through it. It certainly won't be the ease, because it just isn't easy, and it's not perfect. The world's not perfect, and clearly in medicine we see that more than many other people, I assume, that there just are imperfections that we need to just work with, work around, work through, solve, whatever it is, because the answers aren't always there.
My final question to you is, you've accomplished so much already. Where would you want to see yourself go in the next 5 years?
So, I told you I was, I'm finishing up my public health degree. And I think at some point, and maybe it's not in 5 years, but probably in 10, I think I still have a lot to do here where I am in 5 years in working with the Tower Health system and the hospitals, and we've got some work to do in everywhere, and I still have not that old, but I have at some point I will probably go into public health and be a public health officer or something like that. I did many times to go abroad and practice in third world countries, and one that I liked the most was actually Ethiopia, where we opened a trauma center. It was the only trauma center in the country, and still is. And it's fascinating. And I promised them that I would be back at some point to work there. And I think I would like to do that. That would be neat. I've been blessed, over blessed, and it is. And again, it's not really. It's more, I guess, more about me. I enjoy it. I enjoy that. There are certain things of infrastructures, especially in the third world, that they just don't exist. And it doesn't take a lot other than education and attitudes to help change that. Obviously, you need money. But there is a lot of money there, believe it or not. In a lot of these countries, just doesn't get to where it needs to go. So there is a lot of international aid that goes in. They just don't get to where they need to go because no one there really puts that as a priority. Military is often a priority or other things, and yet you have the World Health Organization and the World Bank and other people that are dumping money into a lot of third world countries, but there's not someone that can help operationalize and help the people there organize and operationalize to create an effective healthcare delivery system, which I think is something that we've done here in Reading and we continue to do. And I think that's something that I would like to do, maybe not within the next 5 years, but probably within the next 10.
Dr. Barbera, thank you so much for your time today and explaining your work in the medical field. I wish you continued success in your career, and thank you for all that you've been doing to save lives during the pandemic. Until next time, I'm Justin Gick for One on One.